this is a program that I've been wanting to do for a while. And I have a very close friend who just retired as the CEO of LA Health. And at LA Health, he was responsible for 2.6 million lives. But before that, he was the CEO of a company called Senior Whole Health right here in the Capital Region. And his line is, duals are cool. And duals are cool because they get both Medicare and Medicaid. And there are programs geared specifically for dual eligible individuals. And John Backus is my friend out in LA. So hello to John. He was here in Albany, delivered a very interesting lecture on healthcare in general in America. Fascinating. I think you can still get it on online. And right now we have in New York State, I believe 11 PACE programs, 10, 11 on the way. But when we did this, and I mentioned earlier, I sat on the governor's task force on long-term care reform in 1996. There was one. And we visited the PACE program in the Bronx. And that was an innovative, came out of San Francisco, the Unlock program, and brought PACE into the mainstream. And your bios for all of our speakers, I'm going to introduce them as they speak. The bios are in the program. But I wanted to put together a panel that has a mature PACE program, a startup PACE program, an insurance plan that caters to the same dual eligible population, but not with the same provider network, and that's called the DSNP. And then what if you don't have Medicaid? Because every one of these other programs are Medicaid eligible. What is out there for just someone who has Medicare? What other services? So we have none other than Becky Preve to talk about the Office for Aging in every county that provides wraparound services for individuals to keep them independent and at home. And without any further ado, we're going to get the slides up. And I'm going to hand this off to Michelle. And that is not Michelle on the bottom. She has not undergone the change. I noticed that earlier. So we'll get past that one. I'll give you the clicker. And I think our speakers, if you want to stay, you want the podium? Either way is fine. Because there's two of you. I didn't know how you would do it up here.
Are they on?
They should be on.
Are they on?
Table mics.
Okay.
So you should each have, you can each have a mic.
A little closer. Is that better? All right.
So let me start with Michelle Mazzacco, Executive Vice President of St. Peter's Health Partners, a continuing care network, oversees home, facility, and center-based services. She's chair of the board of the Home Care Association of New York State. Al Cardillo we're going to hear from him later today. She has won multiple awards in the area of long-term care. And with her is indeed Michael Flaherty, the Executive Director of Eddy SeniorCare PACE, leading program growth from 125 to 450 participants. It has expanded in geography and in number, and we'd like to have them talk to you about the Eddy PACE program.
Thank you. Just this one?
Yes, green one.
Well, thank you for having us this morning. We're gonna, hopefully this works. Okay. So that should tell you how excited we were to get the call from Lou to ask us to talk about the PACE program, because we honestly think that PACE is one of the best kept secrets. It's really the program that everyone has been looking for to take care of folks who are frail and want to remain in the community for as long as possible. So thank you for having us. I also just wanted to mention, for those of you who may have caught it, Dr. Oz, the new administrator for the Center for Medicare and Medicaid, visited recently a PACE program, the original PACE program, Unlock in San Francisco. And just to share with you what he had to say after being there, the continuum of services PACE offers seniors from fall prevention, nutrition, fitness, transportation, home care, all with medical services is impressive. And for him, it checked the box of making sure that the public dollars we spend are there to help Americans. So we're going to get into a little bit about what PACE is about. On a real high level basis, for eligibility, PACE is for people 55 and older. I'm extra excited. I qualify. PACE is approved differently than other healthcare providers. So other healthcare providers may serve on a county basis or something like that. PACE is literally approved by CMS and DOH on a zip code by zip code basis. So you have to reside in the area approved, be eligible for nursing home level care per the health department's assessment tool, the UAS, and be able to live safely in the community at time of enrollment with the PACE services wrapped around you. So again, From an outcome standpoint, everybody enrolled in PACE otherwise qualifies to be in a nursing home, and nationally, 94 to 95% are still out in the community. So that's a win, absolutely right there. The average PACE participant nationally is 76 years old and has multiple complex medical conditions, cognitive or functional impairments, and significant health and long-term care needs. But you can see in these pictures, they're having fun anyhow. And this just gives you a sense. Lou said that duals are cool, and almost all of our PACE participants are duals, as you can see. This is national data, but our data shows that really, I would say 90% are duals. And the other thing I'll share, just from a high-level standpoint, in terms of how PACE ultimately works. So we are dually capitated by Medicare and Medicaid. We get a case mix adjusted rate monthly from the federal and the state government. And we basically throw the money into one pot combined, and that gives us the ability to do something that no one else gets to do, which is to spend the money in the way that makes the most sense. So we're able to invest a lot extra into services in the community, into programs like our day center, into transportation, into little and big things that people need to stay at home, and cross our fingers that by doing that, people go to the ER less, they go to the hospital less, and they either never go to a nursing home or they go much later than they otherwise would have gone. And so the concept is that what you save over here, you've spent out in the community. And I can tell you that it works. We started our PACE program in 1996 in Schenectady. And once we got to a certain level of enrollment to spread the risk over, it works, the model works. If you do right by the patient, the program stays afloat. It's a miracle. It's one of the few examples of healthcare that's actually working today. So with that, I'll turn it over to Mike.
Oop, that's not good. We're going to use that one. See, we look like each other, don't we? Thanks, Michelle. So when we split up the deck, I realized that Michelle had it out for me because these next two slides could be their own presentations in themselves. So I'm going to do a high-level overview of them, kind of like driving through Disney in an hour. But hopefully it piques your interest that you could reach out to the Hudson Headwaters folks or the super marketing team in the back there from Eddy SeniorCare. So PACE, Program of All-Inclusive Care for the Elderly. The top part of the slide here really is the Webster's Dictionary, or for some of you younger people, the ChatGPT definition. We are a long-term care program, but I don't want people to think long-term care sometimes feels like I got to a point in life and now I need long-term care. We want to join you as you are aging. You're driving on the highway, we want to merge in there with you, and we want to help you more and more as you're going down that road. To the point where our goal would be to keep you at home and hopefully help you to pass at home, because that's what people want. We can help by bringing in hospice. We can get all of the support you need, but the goal is to get you into the program as early as possible. How do we do it? So again, this paragraph I could take a whole hour on, but PACE is literally everything under one roof when it comes to medical care for seniors. We have a day center where there are activities happening. We have a doctor's office, a home health department, medical equipment, but I want to stop for a second because I want to explain that when you get medical equipment through a PACE program, it's not just the standard, I get a walker every so often, I can get a wheelchair every so often. We get you the equipment that you need when you need it. You lost 100 pounds, your chair is too wide, we get you a new wheelchair right then and there. A ramp on the front of your house, if that's what helps us get you back and forth to your appointments, we're putting a ramp on your house. Our occupational therapist might come into your kitchen and give you an adaptive can opener. No other insurance company is going to pay for a can opener, but in our case, I could put that can opener into your house and that prevents us from having to send a home health aide in. We want to make the person as independent as possible. We don't want to take their lives over. We want to gradually, push in those supports. Rehab services, case management, nursing, dietitians who are going to help meal plan. They're going to help go through refrigerators, throw out expired food. They're going to know that you're going to eat junk food, but they're going to try and work with you as you're eating that junk food. Transportation. We have a fleet of buses. We work with most of the healthcare transportation companies that are out there. We're setting up the transportation. We're calling them. We're booking them. We're canceling them. So that's a job in itself. And medical specialty services, including behavioral health. So we have a network of providers, cardiology, urology, every ology that's out there, we're covering it for you. So whether it's the person seeing the podiatrist for their nails, or they've gone to the hospital and they're in the emergency room, we're covering you and we're keeping track of you. Just because someone goes in the hospital doesn't mean that we just turn our heads and go, oh, let us know when they get out. We follow everyone day by day as they're in the hospital planning for their discharge. And I wrote myself a note on the next slide. Is there really, another program out there when someone's admitted to the hospital and it's time to go home, you have, 6 to 8 people gathering together planning that discharge. How are we getting that person home? Who's going to get the medications? Is there new equipment needed in the home? Who's going to follow up the next day? Do we need to get them to see a specialist right away? We have a whole team of people that are working together to make that happen. A lot of stuff on this slide here. So on the left-hand side, we've got our team, the doctors, the nurses, the social workers, etc. I want to point out a couple of things. So primary care, like any long-term care program, we do have our doctors, but our doctors are seeing 4, 5, 6 people a day. They're seeing our participants for an hour and a half, even a checkup, 30 minutes. I think my last 4 visits at the doctor combined maybe added up to 45 minutes. They are taking care of you from literally head to toe. So when you're going in there and you're not feeling well, they're treating that, but they're also taking a look at what else is going on. Our recreational therapy team coming into the day center, which is not a requirement, but we have people coming in multiple days a week. It is to help with activities for seniors, but on the other hand, it also gives us the opportunity to see our participants. The number of urinary tract infections that we catch because a home health aide in the day center says something to us. I'm looking at our transportation department. The number of times the transportation department reaches out to our rehab team and says, hey, Mrs. Jones isn't getting onto the bus very easily anymore. I think you should check them out. It is a team that is constantly working together. And as I said, every single day for 30 to 45 minutes a day, we are reviewing what happened with our entire patient population, the important stuff, what happened over the last 24 hours, and what we're going to do to keep people safe for the next 24 hours. On the right-hand side of the slide, again, we're a licensed home care agency, so we are providing personal care, medications, but not just providing the medications, we're figuring out how to get those medications to your home. So we have most of our participants are getting them delivered by mail, and if we need to get something right away, we can use a local pharmacy. Hearing aids, which I hear a lot about because it's, they're so tiny these days, they get lost all the time. So you lose your hearing aids, we replace them. Dentures, the glasses, my gosh, we put those all three of the things that seem to disappear all the time. Behavioral health. When people join our program, we do have a network, but we really try to keep people with their mental health providers when they join the program because it is such a specialty where someone has created a bond. And there are so many, only so many providers out there. So if we can find a provider that's working well with a participant already, we try to keep them there. And again, on the bottom there, I'd say, we follow all of our participants, whether they're in the ER, the hospital, we're covering inpatient rehab, specialists, et cetera. We're keeping track. All right, the music is going to start playing soon if I don't stop talking. So again, with PACE, hospital admissions are down. We've got a whole team that is focusing on prevention rather than reaction, as the rest of the medical world does, which is our second bullet there, preventative care. Our participant satisfaction scores are usually just through the roof. This one here, 4.1 out of 5 stars, but 92, 93, 94%. People are less likely to suffer from depression because we do have a whole team that is supporting our participants, and we can get them access to medical specialists. We can get them into those appointments where if you and I picked up the phone right now, we might get booked for a neurologist in 9 months, you know, and our goal is to get you in there a lot sooner than that. How many more have I got? Let's see. Yep. And just finally, a quick on caregivers. I'm not even going to read the slide. We had a presentation about a year ago where we did have a caregiver speak. And she was a full-time caregiver, getting her mom to appointments, taking care of all personal care, everything that was happening in the home. And basically her reaction to PACE was, I was able to spend time with my mom again. You know, I get, you know, it actually, you know, the tears in the room as she said that is that, you know, you guys are taking care of the medical stuff. I get to have mom back again. So thank you.
So if all of you out at home and all of you in the room are sitting there thinking, why doesn't everyone get that kind of care? Why doesn't everyone have doctors and nurses and social workers and a whole wraparound of services at their disposal? And why aren't there more PACE programs out there? We have 10 in New York State. How is it that we can set up a PACE program? What does it take to do that? And for that, we're lucky to have Linda Spokane with us, the president and program director at PACE at Hudson Headwaters. They serve older adults in the Adirondacks. And if you want to talk about rural care, that's what we're talking about here. They led expansion of PACE services across Saratoga, Warren, Washington counties, navigated the approval process to open New York's first new PACE program in over 10 years. Former Vice President of Population Health at Hudson Headwaters, experience in care management, quality improvement. I give you Linda Spokane.
Thank you. That's not mine. Here you go. Oh, this is all yours. Okay. Look at all you missed.
At least it's your picture.
That's true. That's true. And my name. Thank you. So I was asked by Lou to talk about our long and windy journey to open up the first PACE program in over 10 years, which I'm really happy to do. I'm going to give you a brief overview of Hudson Headwaters Health Network in case you're not familiar with our footprint and why we decided to open up our PACE program, our journey and some of the challenges that we faced, and some recommendations to address some of the barriers that currently exist for opening up new PACE programs. So if you're not familiar with Hudson Headwaters Health Network, we are a federally qualified health center or an FQHC, which means that we receive funds from the federal government to provide primary care services to in underserved communities, and we treat people regardless of their ability to pay. Our footprint, as you can see, is quite large. We cover over 7,900 square miles, covering the Adirondacks. And we just opened our 26th health center in Salem. And we are often the sole provider in the communities that we serve. We saw, okay. Yep. We saw over 116,000 unique patients last year, and we are one of the largest employers in the region with over 1,000 employees. Our focus is on providing comprehensive primary care, but we also do a lot more than that. We provide dental, women's care, behavioral health counseling, podiatry, urgent care, and pediatrics. And we are also provide care in over 90 locations. So we provide care in our health centers. We have 2 mobile health units, hospitals, nursing homes, patients' homes, schools, and work sites. So we are really covering a very large area and a large number of people in a very geographically dispersed location. And we've grown significantly over the past 50 years, as you can see here. Our first practice opened in 1974 in Chestertown, New York, and it was run by our founder, Dr. John Ruggie. Probably a lot of you know Dr. Ruggie. He's a visionary. In 1981, he established Hudson Headwaters as an FQHC, and significant growth occurred between 1985 and today. Hudson Headwaters has always been responsive to needs in the community, and we've especially focused on caring for vulnerable populations, including frail older adults. We are the medical director and the primary care provider in many of the local nursing homes in our area. We have over 500 patients enrolled in a Homeward Bound and palliative care program, so that is a primary care model at home. And we also provide palliative care services to all of our patients in our communities. So in 2019, we began to explore ways to diversify our services, and also those services needed to be aligned with the community need. We did a study, and the number of folks that were 65 and older in our region has grown significantly. And over 25% of our patients are on Medicare 65 and older. So we received a grant in 2019 for a feasibility study to open up a PACE program. There was a lot of interest from our leadership in doing that. So we were told originally when we started this effort, it would be about 18 to 24 months to open our program. We are 5.5 years later, just opening our program. And there's a lot of reasons for that. We did complete our feasibility study at the end of 2019, and then COVID happened in 2020. But we did get board approval to move forward with the application in mid-2020. One of the biggest challenges that we faced, as Lou mentioned, is we are the first PACE program, new PACE program to open in over a decade. I actually think it's been longer than a decade since well, now it is. Maybe back in 2020 it wasn't, but so there was no clear roadmap for the application process. You can see that it took over 5 years from when we completed our feasibility study to open our doors. Some of that delay was due to COVID. Some of that was a delay in how we were seeing how to best organize ourselves within the FQHC structure. There actually are no FQHC sponsored PACE programs in New York. We are the first one to open. And there's really only a handful of FQHC sponsored PACE programs around the country. We also underestimated severely the amount of investment required to open up a program. There's the capital that's required to build the day center, which is a fundamental piece of the program. But also, since New York State is one of the few states in the country that requires PACE to become a managed long-term care plan, there's all of the additional capital and reserve requirements related to being a managed care plan. I think the most managed long-term care plans have thousands and thousands and thousands of members. Our PACE program will have a couple hundred, and yet we were being forced to submit the application to be an insurance plan just like all the larger plans. So that was very challenging. And also, since New York State had not reviewed a PACE application in over 10 years, we submitted our managed long-term care application in June of 2022. It did not get approved until January of 2025. Took a long time. The delays were frustrating, obviously. They were costly. They resulted in lots of legal fees, consulting fees, staff resources, but we were able to finally get our program open and approved in January of 2025, and we opened our doors to our first participants in February of 2025. So a lot of hard work went on. Well, the challenges probably speak for themselves. I've outlined them here. The application process is confusing and it's complex. There are current efforts to streamline the process, which I hope happens, but when we were submitting our application, we had to work with many departments within the Department of Health who had little knowledge of PACE. It is the best kept secret, and did not communicate with each other. There were long lag times between when we were requested for additional information and when we received responses for that. There's a lack of transparency, especially around the way the required capitalization and reserves are calculated. Having a clear understanding of the financial resources required to open PACE is really important and would have been beneficial during our feasibility study. There's a significant upfront investment that's required, including building or renovating space for a day center, hiring a full care team on day one, even though by design, this is a slow growth program because it's so resource intensive, as the Eddy just described. We anticipate breaking even 3 to 4 years from now, but that's gonna probably be even longer because we just received a cut in our Medicaid rate by 10%. So that might be pushed out just a little bit further. For new and small programs like us, 1 or 2 high-cost participants will really negatively impact our bottom line. So we're hoping that that doesn't happen. So far, so good. And the PACE model itself is just not well understood. It's not well understood by the state, by the people who are working in the within the department, by the policymakers, legislators, and the consumers themselves. They just really don't understand that the model exists and how beneficial it can be for a specific population. So I've listed here some recommendations based off of our experience. There really needs to be reduced barriers to entry into the market. PACE is really the gold standard of care for this particular population. We should be trying to expand the model throughout New York and scale it. And to do this, the application process needs to be streamlined and made more transparent. Being upfront about the licensing and the capitalization requirements is critical to helping organizations make the decision to open PACE. There's, I know, at least 5 or 6 PACE applications in process, and they're all being hung up with this whole capital, initial capital and reserve requirements. So I would say reduce the initial capitalization requirements for new programs, look at other states' fiscal models for examples on how to do that. And in the same vein, make some capital funds available for expansion and new PACE programs. And finally, recognize and support PACE as a viable and scalable option to keep people out of nursing homes and living at home, which is oftentimes the most preferred option. But despite all the challenges and the delays and the cost, we're really proud that we were able to open in February. We have a fantastic care team, some of whom are here with me today. We have wonderful participants and families. And so I'm just going to be the proud mama of our program. In the next couple of slides, I'm going to just show you some pictures of our facility. So we tried really hard to have some usable open outdoor space, which we accomplished with 2 patios, one in the front, one in the back. We are building a garden in our back patio, so our participants are participating in that, which has been really great to see. And then we really built a day center that is has a very homey feel. Our goal was to provide an Adirondack Lodge feel to it, so we have a large fireplace. We have lots of light, lots of windows. It's very bright and airy. Our families and our participants just love coming to the day center. We also have clinical space. And one area that we were pretty surprised about was how many people come to the day center to get personal care. Because if you can actually deliver the personal care at the day center, you need fewer home care hours, and we all know that home care hours are scarce. So we have been getting good use out of our showers for sure. And then we have clinic space. And the way we're set up is that we are adjacent to one of our health centers. We're in Glens Falls, downtown Glens Falls. And so our participants just go right next door to get their clinical care. And then finally, I'm asked all the time, was it worth it? Was all of this effort worth it? 1,000% worth it. And all you have to do is go into our day center and you can see the smiles on everybody's face. And it's not just the participants, but it's also our staff. I cannot say enough about the staff and how happy they are to be working at the day center and with PACE. And the smiles tell it all. I mean, this is really a program, a unique program that I feel should be scaled throughout all of New York and the country. So thank you.
It is a wonderful promise. It is a future promise to take care of people where they want to be taken care of and to have all-inclusive care. What a great concept. New York has overregulated things since I started doing this 30 years ago. The governor's task force, we visited something called a continuing care retirement community, a CCRC. And at that time, 1996, how many did New York have? One, Kendall at Ithaca. And it was run by the Pennsylvania Quakers initially. And Pennsylvania had 115 CCRCs because they didn't regulate the capital investment the same way that New York did. So stifling innovation is something that we have to overcome. Earlier, we heard about Newark's naturally occurring retirement communities that can be woven into this discussion. But what we're going to hear from next is someone who is taking the duals and taking them into an insurance plan. And we have Medicare, we have Medicare Advantage, and we have Medicaid all rolled into something called a DSNP. And we're all going to learn what that is from Valerie Osborn, the Director of DSNP Strategy and Government Programs at MVP Healthcare. She's driving growth of dual special needs plans across New York with 15 plus years of Medicare sales leadership, known for building strong teams, effective sales strategies. She is committed, as we are, to serving the aging population. She's active on numerous boards and holds a business degree from SUNY Albany. We're happy to welcome Valerie Osborn.
Can you hear me now? Okay. All right. So thank you. So following up after the PACE programs, what amazing programs. Those smiles just melt my heart. I love that. But being in the industry for so long, they are really important programs, right? I think we're all here today focusing on, the aging population of New York, and we have the PACE programs, right? That's kind of the dual eligibles who need a nursing home level of care. I'm going to talk about our dual special needs individuals. And so dual special needs, it's a word that's out there. Everybody's talking about it. What exactly is a dual special needs plan? When we're talking about dual eligible individuals, we're talking about individuals who have both Medicare and Medicaid. And these plans are designed to combine the benefits of both Medicare and Medicaid, focusing on coordination of care and social determinants of health. There's a lot that goes into taking care of individuals. So when you can coordinate the care throughout the insurance company, the individuals do receive a higher level of care. So how do individuals qualify for dual special needs plans? We hear this question all the time. How does an individual qualify for Medicare? Medicare, we get when we turn 65, right? If you've worked enough quarters, you're eligible to receive it at age 65. But you can also receive it if you are under 65, if you are disabled for 24 months as well. And then of course, there's some other reasons individuals can gain Medicare through either having ALS, which is Lou Gehrig's disease, and stage renal disease, or being blind. So most people qualify automatically for all of those reasons. But most people always think Medicare is only for people who are older. Not true. We also have a lot of membership who are individuals who are under the age of 65. And then Medicaid, right? All sorts of confusion between the two, right? Some people on Medicare don't even know they're on Medicare. They call it Medicaid or vice versa. So Medicaid is income-based. You are eligible for Medicaid based on your income and your family size. So in order to have Medicaid, I think we all know it's those lower income and underserved communities of individuals who are eligible for Medicaid. So what a dual advantage plan does is it ultimately combines all of those benefits all in one. If you take a look at this slide, we kind of show you, what does original Medicare cover? Original Medicare is only covering medical benefits. Original Medicare does not cover prescription drugs and all of the extra benefits that are really common and very popular in the dual special needs plans. So when you add both of those plans together, individuals get a better level of care and services provided to them. And we're going to kind of go through those. You can see them on our checklist here, but we're going to kind of on the next few slides talk about the advantages. Ultimately, a dual special needs plan is a Medicare Advantage plan, right? They're ultimately all Medicare Advantage plans, so they do cover everything original Medicare is going to cover, everything Medicaid is going to cover, plus a lot of extra benefits. Since individuals have Medicaid, right, there is no typically out-of-pocket expenses for medical care. And a lot of the dual special needs plans also don't have any cost for prescription drug plans this year, which is great. But they also get additional benefits, right? Medicare and Medicaid don't cover everything. So that is an advantage of enrolling into a dual special needs plan. You get some additional benefits that help individuals, right? It helps provide different levels of medical care. Some things we don't always think about, a new pair of glasses, food on the table. So there's all sorts of different extra benefits that you can see listed on this slide. You can get eyewear, comprehensive and preventive dental. New this year in 2025, all DSNP plans have to offer the New York State Medicaid level of dental benefits. And so all DSNP plans offer the same dental this year because that's a requirement of New York State. Also on a lot of plans, they can get hearing aids. You can get, depending on the plan that you enroll in, MVP, we give you hearing aids every 3 years. And our members are able typically to get 2 hearing aids, 1 for each ear within that three-year time period. And one benefit that there is a lot of buzz about is the OTC and Flex card. I'm sure all of you guys, if you have clients who are duly eligible, people talk about the OTC and Flex card. I see a lot of colleagues and a lot of my peers out here. We talk about this stuff all the time. What does that OTC and Flex card do? It is a set dollar amount for individuals to use for over-the-counter items, right? When you think about things that keep us all healthy, we know it's more than going to the doctor. We know it's more than taking your medication. It's, right, with OTC cards, you can buy toothbrushes and toothpaste and denture cleaner and denture cream. You can buy Band-Aids. You can buy, it's not called first aid cream anymore, but and antibiotic ointments and things like that, right? You can buy all of those additional benefits. You can also use it for healthy foods. I don't know about anybody else, but I know my grocery bill has gone up. So there's an allowance on the card for individuals to also use it for healthy food items, as well as assist with utilities. So on the MVP plans, we give up to $175 a month for those additional benefits. Most DSNP plans across the entire state, because I know we're across the whole state here, have benefits like this. Just we're all kind of the same. It's just those extra benefits can be a little bit different. So one important thing about the dual special needs plan, and this I will say MVP excels at, part of the model of care for dual special needs members is we are required to provide care management. Right? And care management is there to ensure that our members get the care and services that they need. What is the role of the care management team? So you have a registered nurse, you have a community service coordinator, you have a social worker, there's a doctor that works with the team as well. And they all work with the member to provide a plan of care to ensure the individuals are getting the services that they need. Because it's hard for people to coordinate their own care. It's hard for people to coordinate their own services, right? How do people get to the doctors if they don't have a family member, right? Or if they don't have a car? Well, that's what the care team is there for. They're going to be there and they're going to set up that appointment and that transportation benefit for you. What if you're on a new medication and you don't understand it? That is what the care team is there for. They will have our pharmacist call you. One thing great about MVP's care team, we are a small local regional provider here based out of our Schenectady region. All of our care team, they live, we always say this, they live, work, and play in the communities that they serve. So they are very well versed in the resources that are available to you and to your clients. And they work really hard to provide care and services to the members to ensure that they're getting them. They can do things, and these are the most common things, they help members get their medications filled. They help members get authorizations, right? All these processes that can be overwhelming and frustrating to a member. We don't want that, right? We guide people to our care team. They are the most kind and caring nurses and social workers and service coordinators I think I've ever met. They do a lot of the normal everyday things, right, that make it difficult for them to navigate care and navigate the system. So they're there to hold their hand. I always tell this story again, right? We help people set up appointments, and we do a lot of normal everyday things, but then we always do a lot of big things too. We can help people. We had a gentleman locally here in Rensselaer County, and if anyone's heard me present before, I always tell this story because I love that it's right here, right in my own backyard. He was really struggling. He was, kind of couch surfing, going from couch to couch, and he didn't have food. He lost his immigration paperwork. So he became a member, and he decided he wanted to work with our care team. And he was in and out of the hospital, in and out of ER visits, common, right, for people who are struggling to navigate the system. So the care team met with him, and they were like, what do you want to do? How can we help you? What are you looking to do? He wanted to make sure he wasn't going to get deported. He had all his paperwork. He couldn't find it. He didn't know where it was, and he wanted somewhere to live. So before they did anything with his health issues, they set him up with community organizations. They help him set up with legal aid to work through his immigration process to make sure he had his paperwork. They worked with the housing authority to set him up with housing. They worked with the county to help him get HEAP and SNAP benefits so that he was able to have a home place of his own. And through that process, what do you think happened, right? We helped him set up all the services he need. He stopped the ER visits, right? His healthcare improved. And he's still with us to this day. He's one of our very first members from when we launched our DSNP plan back in early 2022. And he always talks about how great MVP was for them, and they're like family. And the care team is there. And again, that's kind of the extreme case, right? Because a lot of people don't need that level of service. But if they do, the care team is there to guide them and do that for individuals. So as I mentioned, right, the care guides are there to help schedule appointments, transportation, care planning, accessing services, equipment, right? Diabetic supplies is a big one that they help with. So they're there to assist our members in whatever care and services they need. We even had one care guide. We're running a commercial. This was a really cute story of our care guide team. They actually sent a teddy bear to a little girl who called in because she saw the care guide on TV and she thought she was pretty. And she wanted an autographed picture of the care guide. So the care guide went out and bought her a teddy bear and got her picture taken and signed it for her and mailed it to her. The care guides are there to assist and help members get the care and services they need. And we're talking DSNP plans, right? I can talk MVP all day, but all plans have care guides. They're there to assist members, and it's one of the advantages of enrolling into a dual special needs plan. And I see Lou, I'm thinking my time is almost up. I'm thinking my time is almost up. So this is our map service area where our plans are available, but know that any county that you work in throughout New York State, there are DSNP plans. There are wonderful brokers that are out there that can assist you if you're not in plan or in areas where MVP is. We're here in local areas. We have great brokers. I see a few of them here today that we have great partnerships with, but DSNP plans are a great option for individuals who are low income and in the underserved communities.
Thank you. So there we have another innovative product using dual eligibles and coordinating care and bringing together streams of money, which there's a theme there. Financing care and putting care plans together that will save money in the long run in acute medical care by providing wellness services and a whole host of other social determinant services in the community. And I couldn't think of anyone better to follow up on that Then Becky Preve, the Executive Director of the Association on Aging in New York. Becky has been a speaker here a number of times, works very closely with Greg Olson at NYSOFA, and the 59 area agencies on aging are a tremendous resource for the people of New York State. Becky's a fierce advocate for older adults. She manages fiscal policy and government relations at the association. She drives innovation and positive policy change across New York State and has, like Greg, grown a reputation across the country as that fierce advocate. Becky.
Thank you, Lou. He makes me sound pretty important. So I'm going to talk really quickly. A colleague of mine called me Becky Andretti this morning, so I'm going to try and live up to that name. And I apologize to this side of the room. There's a blinding light, which is why no one's looking at you, but we know that you're there. Before I kind of jump into my presentation, I just want to say PACE models are absolutely unbelievable. I was just last week in Boston with Charlie Baker, who was the governor in Massachusetts for 8 years, who's now advising Dr. Oz. His #1 favorite program was the PACE program. So huge shout out. And for the DSNP plans, I just enrolled my ex-mother-in-law in a DSNP plan, and the case management staff were really excited that I was helping her because I used to be a hospital discharge planning social worker, so I made their job easy. I'm here to talk about something that I get super, super excited about, and I really appreciate the opportunity. We talk a lot about Medicaid, and Medicaid is super, super important. We fully support all of the work being done in the Medicaid space, but what people don't talk about are the non-Medicaid services that support older individuals in homes and communities. And that is what Greg and I do each and every day, and we celebrate it and we talk about it. And I wanted to kind of walk through really quickly what services are provided through, we call them area agencies on aging, also known as offices for the aging throughout the state. So we're serving people barely above the income benchmark for Medicaid, right? So if you're making $2 grand a month and you're a single individual and you can't get dressed or take a bath, can you afford $40 to $45 an hour for a home care worker? No, you can't. If you don't have those services, are you going to end up in a different living situation? Most likely, there's a high probability there. And so we subsidize those services along with a variety of other services and supports, but really wanted to focus today on our home care model. And our home care model obviously comes with comprehensive case management services, which I cannot say enough about. We see through our case management staff who are all mandated under law and statute to be state certified through Boston University of Social Work, that we are connecting people that fall through every other systems crack that exists, not only in the state of New York, but also nationally. Greg and I got a handwritten letter from a gentleman from the Southern Tier this past year that said he had failed out of Department of Social Services, he'd failed out of Medicaid, he'd failed out of the Veterans Administration, and the only reason that he was alive was because the director of the local office for the aging took an interest in him and was able to get him into a rehab facility where they saved his leg, and he is now clean, sober, and in assisted living because of the case management and the director at that local office for the aging, because we never say no. If you don't statutorily meet our requirements, we're still going to help you. That happens each and every day across the state of New York. So again, full assessment is completed. We authorize services, personal care level 1 and 2, including respite services for caregivers. What are the barriers, right? So I just talked about this program that has insane results. And Lou, I'm going to give you huge credit that you can recite our average client. You've heard Greg and I talk about it enough, obviously. So what are the barriers to our home care program? Because why isn't everybody on it? It's funding. And we're really, really excited about the state budget and the enactment of additional revenue and dollars for our service infrastructure. It does not meet the need. And I get the opportunity to not sugarcoat that. We need millions upon millions of more dollars. And again, when you talk about the economic value of the older population, they're paying $72 billion per year in state and local taxes. $72 billion in a state budget that's a little north of $250 million. If you do the math, that's less than 1/10 of 1% of the overall state budget, even though older people are paying for it. So I will forever advocate that we need more funding for these programs and services. But again, what are our other barriers? Lack of licensed home care provider agencies to fill our cases. You guys have talked about this today. This is a national problem. There's an easy solution: pay home care workers a real wage and we would have home care workers, but we continue to refuse to do that. So that will continue to be a barrier. Again, in the overall state budget, although we're excited about the investment, we use the same licensed home care provider network as the Medicaid system. So it doesn't matter on the payer source side, right? We're using the same aides. There was a $2 mandated wage increase a couple years ago. We fully supported. We got no revenue to offset that cost. So again, we were left out of that in the state budget. We continue to advocate for that $7 million hole to be filled. And then what other barriers are there? Our authorizations are way lower than Medicaid. Why is that? We have a flat budget. So we can't go in and assess someone and actually authorize the hours that they could use because we're trying to stretch those dollars as far as we can. So innovations, this is super, super exciting. When you talk about the home care worker issue, what we noted is that through our network, we wanted to do something a little bit different. And so we are directly employing home health aides through the local offices for the aging. We're doing this in 14 distinct counties. In some counties, we have an exclusive contract where we're assigned aides through the licensed home care provider network directly to the AAA. And guess what we did with them? We made them part of a care team. So instead of an authorization going out and an aide just going into a home, they are embedded with the local office for the aging. They meet with case management staff each and every day, and they are a valued member of that care team. And I have said this from the time that I spent in the hospital to running a AAA to now in this role. If a home care worker came to me and said, Becky, I have a concern about Mrs. Smith, I took that as gospel truth that I trusted more than any physician that spoke to me, because these are really talented, really skilled, really dedicated workers. And making them part of the care team obviously increased their overall satisfaction in the work that they do. And we're continuing to expand this practice across the state because we know it works. What we've seen in counties that have done this is we've seen an elimination of the waiting list for home care services, and we've seen retention go through the roof. So we know it's working. We also utilize the Consumer-Directed Personal Care Assistance Program, which we're very proud of. But again, when the state made the switch to PPL, guess who was forgotten? So we were not included in the switchover, but still ended up having to carry that burden of making sure people were enrolled in the right place at the right time. And what else have we done that's really cool and interesting? Greg talked about this a little bit, and I can't go into too much detail because I got to talk about the federal stuff. We have done a ton on the innovations side of the house, including artificial intelligence in homes, our animatronic pet project, all of the dementia programs that we have to support caregivers, all of the work we have done for working caregivers, the online tech platforms that are completely free for any New Yorker. So I highly encourage you guys to check out the website with links to all of those amazing partnerships. And I'm going to put a huge plug out to Greg Olson. He's leading the way nationally with every other state unit on aging. We constantly get calls from other states to say, how the heck did you do this and why did you do it? Well, we did it because we had to, and we want to serve more people. And we did it with public-private partnerships, which is what all of us need to really look at, because we can't remain just continue to be focused on doing services the way we've done since 1965. We have to innovate. What is the cost benefit? Lou, the only thing you missed on your average client was 83-year-old low-income female, lives alone, 4 to 10 chronic conditions, and needs assistance with bathing, toileting, dressing, grocery shopping. Average length of service, 7 years, cost less than $10,000 per year. These are real numbers. These are real individuals that are receiving services in the state of New York. And guess what happens to people that can't get services in homes and communities? They go to assisted living or skilled nursing facility. But what's the flip side of that? Population is increasing. We're losing demographics in every cohort outside of the 60 plus. Fastest growing segment of the population in the state of New York are those individuals over the age of 80. We're losing licensed skilled nursing facility beds each and every day in the state. We're down to 110,101 that are licensed, but only 97,000 beds are filled, because we don't have any workers, because we don't pay them. So again, we know that the game is in the home and community services setting, and we know that we have a growing Medicaid population. Why the heck are we not investing on preventing Medicaid spend down in the first place when you look at these numbers, right? It's way cheaper, it's way better, it keeps people in homes and communities. And guess what we found? If you're placed on a waiting list for services, and again, these are New York State individuals, 10% of you will go directly to a skilled nursing facility, never touching another infrastructure. 7% are going to spend down and impoverish themselves to Medicaid. And guess what that's going to cost the state? Over $200 million in state savings by serving people through their local offices for the aging. And yet we continue to have to fight year over year to get substantial investments into the New York State Office for the Aging budget. Again, impact of direct employment, these are no-brainers. Good health insurance coverage. I am mortified, Valerie, about what PPL is doing on the health insurance side. I was not aware. We have good county health insurance coverage. Aides get a county vehicle. They're part of that care team. And the aides are able to actually get off that benefit cliff. So when you talk about working additional hours, if you're barely making minimum wage and you get a daycare subsidy, Medicaid, and SNAP benefits, it makes no sense for you to try to work more hours because you're going to fall off that benefit cliff. Being a county employee with all of these different benefits, the benefit cliff no longer becomes that stark reality. And so people want to continue to do this work. And, when you talk about the workforce issue, there are tons of people that want to become a home care worker. But if you can make more money working in a fast food establishment, or, my son in high school made more working on a local farm than someone that is attending to your most intimate needs, that decision isn't very hard to make. So we need to do way better. What are the threats? And I want to really hammer this point out because I think it's so incredibly important. Everybody here has talked about what is happening at the federal level. And what I want to talk about is the fact this has nothing to do with your political party. It has nothing to do with who you voted for. Advocacy right now is about whether or not you agree with what has been proposed by the federal government. And I try to be very, very careful because we have a diverse state in the state of New York, but we also have diversity nationally. It has no affiliation with your political party. It's whether or not you agree with cutting home delivered meals, with cutting respite services, with cutting adult protective services, and services, quite frankly, to the most vulnerable members of the population. If you don't agree with that, please go to our website. You can sign up. You can let your federally elected official know what your thoughts are. But I want to make something abundantly clear, and I've shared this in all of my discussions across the state. These impacts are not for future services. These impacts will be to people that are dependent today on having a home care worker or a hot home delivered meal. Those services will be taken away from the people that are dependent upon them. And when you look at our average client being in their mid-80s and lower income, I can't tell you how catastrophic the impacts of that will be. And so again, there's a link to our website. We made this as easy as possible. With 2 clicks, you can pick your representative, you can sign your name. And again, I don't care who you voted for. I care about what you do when you leave this room and whether or not you fight cuts to the most important programs and services for our most vulnerable. Thank you.
Thank you, Becky. I have a question from the chat room. If we expand PACE and close some of these nursing homes, transition them to housing in the community and senior activity centers, that maybe will work. Can the panel comment on this transition? 110,101, that's the new number. That's a capitated number, folks. Where are people going to go? The numbers don't lie. People continue to age in New York State. How do we expand the programs? Michelle, maybe you can start us. I just want to take a couple of minutes, then we're going to break for lunch and get you fed. But this is too important to just let pass by.
So I really don't want to be the person between you and lunch, but so I feel for what Linda went through first time through. But what I can say as a PACE program is once you go through the process once, it is easier to add additional centers. And so I think one of the fastest solutions is for existing PACE programs to create additional centers in new service areas. We did that. We opened a second site in Latham. And so you're not going through the timeline or the cost that's involved first time around.
Anybody else?
I would just find it not on the PACE model, which is a wonderful model, but numbers don't lie. New York State is home to almost 20 million people. We have almost 5 million over the age of 60. We have 4.1 million caregivers. So you're talking about close to half of the population is dealing with aging or caregiving. We have to fund home and community-based services that keep people in homes and communities and leave skilled nursing facility beds and higher levels of care for people that truly need that level of care that can't be cared for in the community safely. And whether that be expansion of PACE models, expansion of accessible housing, those are all things we need to focus on. And Lou, you and I have talked about this. On the front page of the New York Times in 1986, it said we have a home care workforce crisis. It's 2025.
Yeah.
And we're saying the same thing.